Today we'll be talking about the combination therapy in the management of HIV and AIDS.
Introduction.
HIV and AIDS is an autoimmune deficiency disease characterized by a number of symptoms attributed to the severely diminished CD4 cell count. Globally around the world, it's prevalent that 85.6 million people have been infected with this disease, 40.4 million reported dead, and 39 million people who are still living with it with age ranges of about 15 to 49 years. Now, this virus is known to replicate rapidly, making treatment, efficacy, and therapeutic outcomes difficult to achieve. Monotherapy has had some effect, although challenged by resistance and viral mutation of the organism. Now, the viral structure is known to have a spherical shape with microhistology compatibility proteins, and then it also has an envelope which covers the nucleocapsid. So over to the HIV replication cycle. It occurs in 7 steps. The first process in the HIV cycle is the process of binding. Here the HIV binds or attaches itself to receptors on the surface of a CD4 cell. Then they fuse together. This process of fusion allows the entry of the HIV cell into the CD4 cell. Then the process of reverse transcription starts, where the HIV RNA is converted to DNA. This conversion allows the HIV DNA to enter the CD4 cell nucleus and combine with the cell's genetic material cell DNA. And after that process, the cell enters into the nucleus of the cell. Then the process of integration occurs. Here, the particles of the HIV then starts to integrate itself with the DNA of the CD4 cell. Then after that, it starts to replicate, making use of the machinery of the CD4 cell to make long chains of HIV proteins, and then which are the building blocks for more HIV. After that process is the assembly. Now the new HIV cells that are newly produced move to the surface of the cell and assemble into immature cells, which are at this point uninfectious. And after that, it then becomes the budding stage. At this budding stage, the newly formed immature HIV pushes itself out of the host, and the new HIV cell releases protease. This protease is an enzyme that breaks up that long chain of the immature virus, creating the mature infectious virus, and at this point, a newly formed HIV cell.
Mechanism of action of antiretroviral drugs.
The viruses are classified into the protease inhibitors, the fusion inhibitors, the CCR5 antagonists, the non-nucleoside reverse transcriptase, the attachment inhibitors, the nucleoside reverse transcriptase. The nucleoside reverse transcriptase, these ones, they bind and block the HIV reverse transcriptase from converting the HIV RNA back to the HIV DNA, and they prevent elongation. An example is tenofovir and zenofovir. The non-nucleoside reverse transcriptase inhibitors, these ones, they also act like the nucleoside reverse transcriptase inhibitors, but they bind on a different receptor. An example is nevirapine. Then we have the protease inhibitors. Protease inhibitors, they inhibit the protease enzymes from converting an immature HIV to a mature HIV, which bind to the CD4 cells. Then we have the fusion inhibitors. The fusion inhibitors, they prevent the HIV envelope from merging with the host CD4 cell membrane. Then they prevent the HIV from entering into the cell. Next, we have the CCR5 antagonists. The CCR5 antagonists, they prevent the CCR5 co-receptor from appearing on the surface of the cell, and they prevent the HIV from binding to the cell CD4 cell. And next, we have the post-attachment inhibitors. These ones, they prevent the further attachment of the HIV into the cell of the host, and they prevent the elongation of the HIV cell. Next, we have the integrase inhibitors. The integrase inhibitors, they prevent the HIV DNA from binding to the DNA of the cell, thereby preventing the further elongation of the HIV cell into the cell.
Combination rationale.
Combination therapy is a medication comprising of 3 or more drugs used in the treatment of HIV. They can be formulated as fixed dose, used in reduction of viral and improving quality of life. Combination therapy can be formulated as pre-exposure prophylaxis or post-exposure prophylaxis. There are 3 different classes of combination therapy. The first one is protease inhibitors based. An example of protease inhibitors based is atezolizumab plus cobicistat. The next classification is integrase strand transfer inhibitor. An example is dolutegravir plus RPV. The third is non-nucleoside reverse transcriptase inhibitor. An example is atazanavir plus tenofovir. The combination therapy rationale, what makes it very effective is potency and efficacy, reduced side effect and toxicity, and better resistance.
Starting from where my colleague stopped, I would want you to understand the reason why these HIV drugs are combined. Imagine me carrying a big bag of rice alone. It will be so heavy, but when I call two hefty men to help me lift this bag of rice, it becomes way lighter and easier for me to carry. So let's refer this to drugs. When one HIV drug is given, sometimes the drug might gain resistance in the sense that when this drug comes into the system, the HIV viruses will fight this drug and the drug will not work against them without it reacting or reducing the viral load. So when 2 or 3 HIV drugs are being combined, they're able to go into the system and fight this HIV virus, suppressing the HIV virus. And we have a whole lot of classes of HIV drugs. And when you combine 2 or 3 classes, it helps to reduce the viral load. It also helps in efficacy and potency of the drug. So we have non-nucleotide transcriptase inhibitors such as doravirine, efavirenz, ripivirine. It can be combined with 2 nucleotide reverse transcriptase inhibitor drugs. And the reason why this is combined is that these 3 drugs which I mentioned have low barrier to resistance. They are easily resisted, but when it's being combined, it works better. Doravirine has CNS tolerability advantage over efavirenz and more favorable lipid solubility. Doravirine also has fewer potential drug interaction in the sense that when you take this drug with another drug, it does not really interact. You can take this drug with other drugs and it will not have a bad effect. And also we have doravirine does not cause weight gain. There are some HIV drugs that when you start taking it, the person starts gaining weight excessively, but doravirine does not cause weight gain. We also have nucleoside or nucleotide reverse transcriptase inhibitors that are being combined. We have abacavir plus lamivudine, abacavir plus lamivudine plus zidovudine. These are just names of drugs. There are a whole lot more in the list. We also have boosted darunavir. Boosted darunavir just means that this drug darunavir is combined with ritonavir, which is another drug. Ritonavir helps it not to be easily metabolized. Instead of this drug to stay like 10 hours in the system, due to the fact it's not easily metabolized by blocking CYP3A enzyme of the hepatic cytochrome P450, it helps it to stay like 15 hours or 10 hours more in the system. We also have drugs like integrase strand transcriptase inhibitor, which is a class of HIV drug. It can be combined with 2 of non-reverse transcriptase inhibitors drug. We have vartagin and cobiscat and tenofovir alfenamide and tenofovir disoprozil. The difference between this tenofovir alfenamide and dysprosium fumarate is the fact that dysprosium fumarate is a prodrug and is not easily metabolized, unlike the other one. One thing you should know about this is that they have different mechanism of action. They help to reduce the viral load in the sense that they reduce the HIV virus load, and there is low incidence of resistance. The HIV cannot easily fight 3 different drugs, and there's also better efficacy in this drug. There are a lot more like non-nucleotide reverse transcriptase inhibitors plus 2 nucleotide reverse transcriptase inhibitors like doranavir, tenofovir, disoprozil, and lamivudine or doranavir. There's also efavirenz and tenofovir alfenamide or dysprosium fumarate, and a whole lot more. The list is so long, but the main reason for this combination is just so it can work more better and last more longer in the body.
Factors that determine the preference of one ARV to another.
What are the effects of HIV medicine? 2. Potential drug interaction between HIV medicine or between HIV medicines and other medicines. Third one, results of drug resistance testing. Confidence of the treatment regimen, treatment compliance, cost, drug resistance, and side effects and toxicity levels.
Comparison among ARV combination therapies.
We are comparing based on the following parameters: the cost, the efficacy, the dosage simplicity, and toxicity. So comparing Evotas, Prescobis, and Dovato. Cost, the Evotas is strongly favorable compared to Prescobis, which is just favorable, and Dovato, which is unfavorable, that is on a high cost. Efficacy, they are all strongly favorable. Dosage simplicity, both Prescobis and Dovato, they are strongly favorable compared to Evotas, which is just favorable. Now talking about the toxicity, Evotas, Prescobis, they are both favorable compared to Dovato, which is unfavorable. Comparing 2 other antiretroviral combinations, which is Triumeq and Atripla. Triumeq in cost is favorable and Atripla is more strongly favorable. Now talking about the efficacy, they both are both strongly favorable. Now dosage simplicity, they are just favorable, and this toxicity, both of them are unfavorable for female of childbearing age. Then talking about pregnant women that are in need of antiretroviral therapies, we can recommend for their own health first line treatment, which is dofudine, plus 3-TC lamivudine as a backbone in combination with NNRT, non-nucleotide reverse transcriptase inhibitors, that is nevirapine. Thank you.